Williams is my name. Does diet play a part in melanoma?
Yeah, very good question about diet and melanoma. So there's been lots of research on diet and cancer, and particularly some of the cancers that are quite common in Western countries, in Caucasian people, like bowel cancer and breast cancer. There are dietary influences. No evidence that diet has much role in melanoma to date. And, why might that be the case? Well, we know a fair bit about what causes melanoma. It's UV radiation, and it causes mutations inside those melanocyte cells to turn them cancerous, and diet doesn't appear to have a major effect on that process. Okay, so whether it might have some minor effects as to whether the cells can establish a true cancer type to their growth and things is still under investigation, but to date there doesn't appear to be any significant role for diet in melanoma, which is very different to other cancers where they're clearly, especially bowel cancer, clearly there are roles there.
Thank you.
Peter Auden. Question is to Grant and possibly also Michael. We have a son who's in a trial in the States, in Denver, stage 4. It's the BRAF trial, and I don't know if you can comment or not, but Kay and I would be interested to have any feedback on what's happening, because we believe you're involved too, Grant.
Yeah, so there's now a lot of activity in clinical trials around targeting BRAF, and Michael spoke about the first drug that was put into trials, vemurafenib, and that was also what I spoke about, but there's the other drug Michael referred to, dabrafenib now, and we're particularly interested in adding other drugs on top of the BRAF inhibitor to make it work more effectively. So, there's a very, very large amount of activity happening, and I think about this BRAF thing really as it's a bit of a foot in the door now. We really know one major thing inside the melanoma that can be effective, but we've really got to keep doing more trials and more research and make it better and better and better all the time. So, I think it's fantastic that your son's being involved in a clinical trial, because that's the way that we're going to make better and better advances all the time. Without all the details, so I can't comment on a specific case, of course, but no, fantastic that he's being involved in a clinical trial. I think, it helps him, and it very much helps the melanoma community globally for people that are involved in clinical trials.
My name's Barb Ricks from Adelaide, and Michael, I'd like to ask you, I'm stage 4, having been treated with photomustine for 10 months with a good result. Now, if I don't continue to be well, am I eligible to go on a clinical trial?
That depends.
I see. Yeah.
And it depends, as I mentioned, on the eligibility criteria, and they're particular to each trial.
Yes.
So it would have to be a question you'd have to talk to the investigator about for that trial. So, the Cancer Council would provide some information about the trial. The companies themselves often provide some information, but really best to see the investigator who's running the trial and get their view on it.
Thank you.
Perhaps I might just make one comment too about trials that, they're so important about moving the field forward for everyone. They're just, absolutely vital. And yet, in Australia at the moment overall, it's only around about 5 or 6% of patients with cancer will be involved in a clinical trial. We've got to do much better. I know my colleagues in Paris at the Institut Gustave Roussy, their big cancer centre, 26% of patients that walk through the door will go onto a clinical trial. And one thing that we can do as a community in Australia, and I really do emphasise the we, meaning everyone in this room, is we really need to encourage our hospitals and our government funding agencies to make clinical trials more available, because it should be, can I go on a clinical trial? The answer should be almost certainly yes for everyone, instead of, well, there's all these complex eligibility things that Michael went through so well. So I think we've got to do better. We've got to get up towards that 26%. The Institut Gustave Roussy, or even in the UK now, it's they're now heading up towards about 15% of people with cancer being involved in clinical trials. In Australia, we're way behind.
Yeah, Paul Newman's again. Do either one of you, just with the catching melanoma, is it only the sun that causes it, melanoma, and can your family catch it like from the sun as well, or is it like hand down, like through your genes and that, to the rest of your family?
Great question. So in Australia, really, it's well less than 5% of melanomas can be attributed to genetic factors running in families, so it's very, very uncommon, and it's more common in other places in the world. And the reason for that is that in Australia, melanoma just is caused by the high levels of UV have with our beautiful climate and sunshine, and the fact that most Australians are in fact Caucasians and have fair skin, and that's a lethal combination. So there are genetic factors in a small percentage of people with melanoma. What is sort of an interesting debate that we have going on in the professional circles is whether that really matters, because, and you might say, oh, well, of course it matters if it runs in families, but one argument is that in Australia our rates of melanoma are so high, everyone should be sun smart. It doesn't matter if it runs in families or not. We all need to think about preventing melanoma and catching it early, and removing it surgically before it has a chance to spread wherever we can, and that the genetics is not so important. But you know, I'm an enormous believer in that you have to understand the disease to treat it effectively, and therefore if there are genetic factors, which there are in a small percentage, we do need to study that and understand that as well.
So it's the only cancer we can really stop ourselves, isn't it? That makes me so angry about it, you know.
Great point, fantastic point. So there are a few cancers that are really clear. So we know that there's a cancer called mesothelioma, which can be caused by asbestos. Okay, and there's a really strong relationship there. There's melanoma with UV. There are certain types of lung cancer with smoking. There are now emerging, because people pleasingly are smoking less. There are types of lung cancer that are not related to smoking, getting a bit more common, but there's still some that are absolutely due to smoking. So there's a few cancers where it's sort of really clear what the cause is, and exactly as you say, melanoma is one of them. Yep.
My name's Bevan Whittaker, stage 4 melanoma. I was interested to hear you mention that there's a possible conflict of interest in those diagrams that you had up on the screen, and every lecture I go to, this is commonly discussed, that bias and conflict of interest. The money trail also, or following the money trail, also leads to no interest. In other words, people have no interest in doing something unless there's going to be a return. What say, for instance, that lemon skins would cure cancer, hypothetically, grated lemon skins? Have you heard the topic that says that because lemon skins can't be copyrighted, hence drug companies have no interest in putting up $1 billion to prove up the product, only to have everybody grating lemon skins that they pick from their backyards?
Oh, yeah, another excellent question. So I think there's an element of truth in that, and I think that's the role then for national taxpayer-funded granting agencies. They really should take on that task of doing the trials that the companies have no commercial interest in doing. However, a lot of drugs in their path to marketing approval achieve something called orphan drug status. So a lot of companies are actually pretty determined if they can protect, and I didn't mention intellectual property protection. That's really what this is about, is being able to protect what you've got so you can have a monopoly on selling it for a period of time. If you can't do that, then why make an investment? Because you just lose your money. Someone else will take it from you by selling a competitive product. So, but nonetheless, companies do follow this orphan drug status where they have a small number of patients who could benefit, and there are concessions made in the commercial development. But there's got to be some intellectual property protection. This is to prove, the question you're asking is to prove that lemon skin peel will actually be a benefit. I guess if it really is so fantastic, the other advantage is that a lot of people will be taking it already. And you see this with a lot of alternative, so-called complementary and alternative medications, that a lot of people do take them even when they're on the drugs if the trial doesn't prohibit them. So there's some belief these other substances can be of benefit.
Yeah, I might comment on that as well. I mean, I think we've actually got reasonable balance in our system. You know, as Michael's referred to, there are ways of funding research in cancer for novel things that don't have a commercial basis. Particularly in the United States and Europe, we're lagging again in this country about the ability of doing clinical trials that are not sponsored by pharmaceutical or biotechnology companies. There's a lot more that happens elsewhere in the world. You know, more than a third of trials are done away from any industry sponsorship at all. So if the lemon pills work, we absolutely have a path. So I hold a grant called a development grant with NHMRC. That's government money to develop a new cancer treatment. Okay, so that's government money that is being used to develop a new treatment. And there are avenues to move things forward if they're really promising. And personally, I would absolutely, without any hesitation, put an absolute kibosh on any idea that there's a conspiracy to hold back cures for melanoma and cancers by industry. There's no way. There are so many checks and balances. If I see something that really works and some industry tried to slow me down in developing it as a treatment for my patients, I would never sleep. That would be, the professional misconduct by me. If I see something that works, I'll do everything I can to move it forward. And there's so many people involved in this cancer treatment worldwide that there's no way there's any conspiracy to hold back, cures for cancer by the pharmaceutical industry. It's just the opposite, actually. They're desperate to move things forward as fast as they can because that's what makes money for their shareholders.
And certainly also to say there's robust, there may be no conspiracy, there's robust competition between companies. So they're always looking ahead to see how they could get the advantage, and in fact that does affect trial design. But as you may realise, a lot of companies don't have, until recently, a lot of drugs in their pipeline. So things they're looking to develop that will go through these phases of clinical trials that I was mentioning. And there's been, except very recently, a fall-off in new drug approvals. And the way a lot of large companies, which are cashed up, have dealt with this, and these are global companies, is by looking very carefully at biotechnology companies, so companies that have more risk capital involved in developing a drug, where they're doing the hard yards in showing that it actually works, and then providing sufficient interest for the global pharmaceutical company to either partner with them or have that company be acquired by the global pharmaceutical company, because only that company has the provision to conduct these billion-dollar global trials, or series of trials.
Sorry, my name's Annette Sinclair and I'm from Wagga. My first question, I have two questions, sorry. My first question is regarding, we focus a lot about on, our skincare and watching changes in moles and things. Can you explain to me how, or I'm not sure if you can answer it, about people that are diagnosed with melanoma with no primary skin lesion?
So
I'll let Michael answer this because this is an area of some interest to Michael. Yeah.
Sorry, I missed the last bit.
Oh, sorry. It's patients that are diagnosed with melanoma but they have no primary skin lesion.
Oh, right. What to do about that?
Or how does it happen?
How does it happen? Oh, I see. Okay. Well, it's probably about 10 to 15% of cancers that would be like that. So it's not that uncommon. It's not that uncommon. There is some evidence that melanomas have been caught with a lot of lymphocytes, the cells of your immune system that can fight melanoma, being caught with them around them and being destroyed, so-called regression. So that might be the mechanism by which the primary tumour can be killed off, but the cancer that is now spread in the body has already changed from the primary tumour. It's spread to the point, as Grant said, it's moved away from the skin and is more aggressive by definition because it's able to live elsewhere in the body and not just be confined to the skin. And there, for reasons that really aren't understood, the immune system can no longer control it. I mean, there's some clue as to why that can happen, and this drug, ipilimumab or Yervoy, is one clue that the immune system has checks on it that stop it getting out of control. And if you interfere with those checks, you can actually unleash its activity against melanoma, and that's how Yervoy works. But it's a fact of life that some melanomas we don't actually find the primary, which, and a very important practical point to make from that is if someone does develop melanoma that's spread, they should always have it tested to see whether there is a treatable mutation, such as a BRAF mutation, because it could be a new melanoma that has regressed, that has arisen as the spread, not some melanoma that was cut off 10 or 15 years ago that could otherwise be blamed. So I think that's a very important practical point.
My second question, well actually it's not even a question, it's probably something you won't be able to comment on. It's around the clinical trials and the ethical restrictions. And I guess from a mother of a child that you're trying to get onto a clinical trial with no other treatment left, the frustrations of those limitations and the goalposts keep moving.
No, I know exactly what you mean. I've been in this predicament many times myself. I think it's important to keep trying though, because every time that I face this predicament with patients where they're not eligible, I always ask the company and get a formal written response. Sometimes companies will apply what's called a waiver, so it depends on the particularity of the circumstances. It may be possible to have a patient go into the trial with a waiver. Some companies refuse to have that for a particular trial. But I think it is always important, and often because they're global trials, their head offices, say in the United States or Europe, that communication be made and that a response be got back. And then obviously to explore whatever options there might be elsewhere in the country or even overseas would be the other thing to consider. Of course, a much more difficult path.
I probably should just make a comment about this concept of waivers. So the Food and Drug Administration in the US have put out a policy that there should be no waivers on clinical trials. So I think the cases where it can happen that's going to stop, unfortunately. My local ethics committee will not grant any waivers on eligibility criteria. And this is, where is that coming from? It's really coming from the regulators, the government regulators of the process of assessment and approval of new treatments about this no waiver policy. So although it has happened in the past, I think it's going to disappear. And the best way of dealing with that is to actually get more clinical trials with broader eligibility. So that's why we need to encourage everyone to invest in more clinical trials, hospitals, governments, industry, to invest a lot more so we can do more clinical trials and more available for patients.
But to take that a step further, I mean, there has been movement at the station in that patients formerly had been excluded from going into melanoma trials if they had spread to the brain. And the drug dabrafenib, the other company's drug, GSK's drug, was shown actually in a trial largely initiated in Australia by a group in Sydney, Melanoma Institute Australia, to work in the brain. And as a consequence, a phase 2 trial was designed that's just been reported in the United States to show that this drug is pretty well as effective in the brain as outside the brain. So this is really going to change the paradigm of treatment for melanoma, and this applies also to vemurafenib, not quite done in a formal way as for dabrafenib, but there is a lot of evidence that it does work also in the brain. So this is a change, and the regulatory authorities are having to take this on board and how to deal with drugs moving forward.
Thank you. I think there's some questions up the back.
My question is to Michael. Michael, you mentioned people possibly being excluded from a drug trial if they were taking up other perhaps treatment options. And I'm thinking if somebody was wanting to be part of a drug trial, what other treatment options would they be wishing to undertake that might see them excluded?
Well, again, it'll depend on the particulars of the trial. So some drugs will interact with St John's wort, for example, St John's wort, which is a herb used for depression. So they'll interact with that and affect the way it gets cleared from the body. And it might lead as a consequence to unwanted effects of the trial drug. And for that reason, patients would be excluded from taking that at the same time they're on the trial. Many of these complementary and alternative medicines contain active drugs, so they can interact and they can do things you don't want to have. The other thing about many of these medications, if I can call them that, is they're unregulated. And in fact, you're not warranted to know the companies aren't warranted to know what's in there or put what's in there. And in fact, they can put things in there that shouldn't be in there, but would have some positive effect. Some of them will have dexamethasone in there, a steroid medication would make people feel great. And that's why they might sell more. So all that they're really allowed to do is make some broad health claim rather than specific claims, which you require a clinical trial to demonstrate otherwise. But there are very few clinical trials done with these medications. So that's in general the reason why patients are excluded, but it does depend on the particular trial.
One more question before we break. Yeah, just behind you, yes.
Hi, Terry Sinclair, stage 4 for a couple of years. Just started the COMBI-D trial, so it's all good. I was just wondering, vemurafenib's now, sort of on the market, around there anyway, and as dabrafenib goes along and gets towards being on the market, when it passes all its things, how will doctors choose, is it going to be like antibiotics, the way doctors choose the next drug rep that comes in, promotes it? How will they choose? What's the difference between them?
Well,
Why are they the same drug?
No, they're not exactly the same. And it could be that in fact they won't be in the market together as dabrafenib and vemurafenib. I mean, if this COMBI-D trial is successful and the combination is actually better than dabrafenib alone, then that might be the combination that the company goes to the regulatory authorities with, which of course creates a problem for Roche and vemurafenib. So, marketing problem. But that's unknown at this point because we don't know the result of the trial.
Well, we've got one lady who's asking, yes, this is the last.
Hi. The gentleman that was talking about lemon skins, I doubt very much, Dr. MacArthur, if you had any money, you'd invest in that. Any doctor I've spoken to about nutrition, any training they have in nutrition, any foods, alternative things, and they poo-hoo everything because it hasn't had a trial, it's not proven, so just forget about it. I think there's a large area of research that needs to be done, and I don't think there's going to be... Take this as a comment because I don't expect you to answer this, but there's no interest in promoting the lemon skin, the almond, the kernels, the vitamin that are necessary, the food that you shouldn't eat, the foods that cancer patients shouldn't eat. It's not a big thing, but there's lots of hoo-ha about other things. Anyway, I'll just leave that as a comment because I don't think you can answer that. And I don't think there's anyone who's going to do any trials on lemon skins, although we do read a lot about it. But I do have sort of a question. I've been in a bit of a dilemma in that I've been offered a place on a trial that is first human trial. So the 20-page information that I received at the hospital gives me really no information as to what to expect, no side effects, Whereas when we were doing the vemurafenib, there was a whole list of things that could or couldn't happen, 20, 30 side effects. This has nothing. And I'm wondering, how does one make that decision? It's sometimes, you know, the unknown makes me think, because I don't know that there's another person, perhaps even in this room, who's in the same position. How do I make that decision? I'm just lost as to what to do.
Grant will try.
Yeah. So I think the first point you make is actually a good one, and I'll rephrase as a question and answer that, and then I might get Michael to comment on issues around consent forms and how you can go about getting extra information to clarify your involvement in a clinical trial. But I'll deal with the first statement. So this is a really good point, because, and we grapple with this every single day, which is, where do you put your priorities in research? I mean, this is, we live or die as to whether we have a job next year on this very question, which is, where do we put our money, our energy and our time? And we think about this all the time. So the way you do that is you look for clues and preliminary evidence, then you go and you get a bit more evidence, and then you start to build up till you get to a point where, wow, this is pretty interesting. We need to do the randomised trial of, say, lemon skins versus standard of care otherwise, or some other dietary intervention. So people are very interested in that, but it's a matter of seeing enough preliminary evidence there, and that can sometimes come from the lab, it can sometimes come from observation about how certain patients are doing, to make you go that extra step to say, well, I'm not going to work on BRAF anymore, you know, I'm going to put that aside and instead work on lemon skins. You'd need some good preliminary information to build that on and to build confidence. And so we are thinking about that all the time. So, and that's why, you know, some things move forward and others don't. But, you know, anyone that's got an interesting observation, they've got an idea, a hypothesis about something, even if it seems a bit out of left field, you absolutely need to share it and talk about it so that we can move the ideas forward.
So to answer your question about informed consent in the first-in-human study, I think it's fair to ask the investigator, if they haven't put it in the document, about any animal work that was done, because usually to get any idea that you would do this in humans, you're going to have a preclinical proof of concept that's developed in animal models. So hopefully some mice have already answered some questions for the investigator, so that you'll have some idea in mice that the drug is active, for example, and that it didn't cause any major problems in mice. And then maybe some other animals have been looked at as well to increase the bar for safety. That's not happened. Right, well, so maybe that's all that's known, which is why it's the first time in human study. I mean, you'd have to look again at the particulars of what you're talking about, but other than to say that in that sort of study, if it's properly conducted, you'll be very closely monitored, so that people are watching over you like hawks to see if you do get any problems related to the drug you're receiving. And there are stopping rules that should be in this trial as well. Sure, but that's because it's already been, yeah. That's because for vemurafenib it was known, but at the time when it was first tried, that wasn't known. So the patients are really guinea pigs.
Can we draw that to a close, please? Because and please, if you wish to continue that discussion during our break, by all means do so. Look, I think this session, hopefully from your perspective, that you can gain some comfort from the fact that people like Grant and Michael and their colleagues are working very hard to find the evidence to provide you with information about various treatments and way in which they can make advances in the treatment, identification, etc. of melanoma. And I think also you can draw some comfort in the point that Michael has shown in terms of the way in which trials are conducted, that your comfort, your protection from an ethical point of view, from a personal point of view, that they are well covered, so that On your behalf, can I thank both Grant and Michael for their presentation, and as I said, I think you can feel comfortable that the quality and the work that they're doing is taking research further forward. Thank you very much indeed.